Bom dia a todos. Nós estamos aqui mais uma vez fazendo uma transmissão ao vivo, direto do ParaValvular TV. Hoje é 18 de julho de 2020, são 10h30 da manhã aqui no Brasil, no Rio de Janeiro. Hoje é uma transmissão especial, diferente. Nós temos um convidado internacional que fala inglês, então hoje a nossa transmissão vai ser em inglês. Depois nós teremos a transmissão, a tradução disso para o português e outras línguas, como os senhores já sabem que acompanham aqui o canal. Deixa eu trocar a chave agora e começar a falar em inglês para que o professor possa participar junto com todos os presentes. Good morning, everybody. We are talking from the Four Valves TV channel, Structural Heart channel of you, and today we have a special transmission with a special guest that I would introduce him in the end of the other colleagues. We have today a transmission about paravalvular leak, a complex case, and we have in this transmission Dr. Edgard Quintella, my colleague from Rio de Janeiro, and the other colleague from Rio, Dr. Max Lacoste, this famous guy from ECHO, and we have two strong guys that will show us the strength of the interventional structural heart in the countryside of the Brazil, Pablo Tomé and Felipe Toledo from Piracicaba, a city 200 kilometers from São Paulo. And at last but not least, our special guest, Professor Chet, Rihal, a former chair of cardiovascular medicine and an expert and probably one of the biggest experience on paravalvular leak closure from the Mayo Clinic. Professor Chet, could you say good morning for our attendee?
Of course. Good morning, everyone. It's a pleasure to be here with you, and I would like to thank all my friends in Brazil for the opportunity to present. I'm very excited to participate, and I look forward to a very engaging discussion with you. So thank you again for allowing me to be here.
Thank you very much. Our transmission today will be split in two parts. The first part is a lecture from Professor Chet, and the second part it's a complex case that Pablo, Felipe, and Max has done. And during this presentation of this case, we can discuss a lot of skills and techniques, and Professor Chet will help us to understand better this new field of interventions. All of our transmissions are learning sessions, and our intention here is to transmit and share knowledge and engage more professionals from interventional heart, structural heart, that would want to learn how to do new work with new devices. Professor Chet, could you start to share your screen with us, please?
Let me know when you see it.
Okay.
The screen is on.
Good.
We can see your screen. That's okay.
You see the first slide?
Yeah, we can see your first slide.
And the audio is okay?
Yeah, it's very nice.
Good. Perfect.
Shall I go ahead and start?
Yeah, please.
Okay, so thank you again. I'm here to speak about paravalvular leak closure. And it's a very interesting story how I got interested in paravalvular leak closure. Like many important things in medicine, it goes back to the unmet need of a single patient. I recall a patient probably about 15 years ago who presented to our hospital with severe heart failure and a large hole beside her mitral valve. And one of my colleagues said to me, Dr. Rihal, why can't you figure out how to put a plug in there? And that's how the journey started. I started thinking about how we can put plugs in there, how we will develop the techniques, what sort of plugs we will use. And as you mentioned, we now have a very large experience of this procedure, and I would like to share this experience with you. Disclosures, everything we do essentially is off-label. We use approved devices. Here in America, we have a limited number of devices, but it is off-label. Now, the first important point I would like to make about periprosthetic regurgitation is that it is more common than we think. Up to 17% of valves in some series actually have evidence of PVL or paravalvular regurgitation. It can present with hemolysis or heart failure or both. It can be very difficult to treat medically. There's almost nothing we can do medically other than give diuretics. And usually it is underestimated by transthoracic echocardiography. There are many causes for PVL and many risk factors. I've made a list here of some of the more common ones that I've observed, including annular calcification, tissue friability, endocarditis, any chronic inflammatory disorder. The recent institution of corticosteroid therapy, I have seen valves being just fine for 10 years, and then the patient gets prescribed corticosteroids, and all of a sudden the sutures start to pull out. And finally, implantation technique. We know that pledgeted sutures, when the surgeons use them, are associated with less PVL. And so all of these things can conspire to cause paravalvular regurgitation. And we know it can affect any type of prosthetic valve in any position, like this single disc tilting valve. Now, anatomically, there are favorable and unfavorable varieties. The top panel shows a relatively discrete PVL around this mitral bioprosthesis, which we can quickly plug, but the lower panel shows a frank dehiscence of the valve, which is not good for percutaneous closure and is likely better treated surgically. I hope the three-dimensional TEE is coming through now on the transmission, but the real-time 3D TEE has revolutionized our practice because it gives us complete spatial orientation around the valve and allows us to identify where the PVL is and the anatomy of the PVL. So as you can see in the top right quadrant, there's a gap between the sewing ring and the atrial wall, indicative of where the sewing ring is. Now, one of the most important things that we learned early was how to visualize these and how to communicate between our echocardiography colleagues, who are our eyes, and the interventionalists. So, this is the view that our echocardiography colleagues typically will use in the operating room. This is the so called surgeon's view. Looking from above, looking down at the mitral valve, you see the mitral valve is here, tricuspid valve to the right. And this is the view that they are used to using. This is not the view we use in the cath lab. This is the view we use in the cath lab. I call this the interventionalist view. In this view, we're looking up at the mitral valve in our left anterior oblique caudal projection. So the mitral valve is on the right. This is posterior. This is medial. And the aortic valve is to the top left. So you notice this is 180 degrees flipped. So this is why we never say the leak is at 12 o'clock or 3 o'clock or 6 o'clock or 9 o'clock. It's because we are in different time zones. And we have to use, and we really must use, anatomic terminology. So the terminology I would advocate we use to say anterolateral at the base of the left atrial appendage, anteromedial by the aortic valve, medial by the interatrial septum, or posterior. So we always use anatomic terminology to communicate with our imaging colleagues. There are a number of different configurations of devices that we can use. I believe in Brazil and Europe, you have many more devices that can be used. But here, we tend to use the thin braid AGA devices, particularly the AVP2, because it's very easy to use, it's easy to put multiple plugs, and it's malleable, it's soft. We have the AVP4 as well, but we don't use it very much other than for post-TAVR paravalvular leak. And the AVP3 will be a nice addition, and it's currently in clinical trials. We also have access to these, that the ASD occluders, the muscular VSD occluders, and the ductal occluders. But these are thicker braid. These are stiffer devices, and residual high velocity jets through the device can cause hemolysis. In our experience, it has been 15 to 20%, which is why we tend to favor the thin braid devices. There are now newer devices like the Occlutech device that are coming, and hopefully will be even better for paravalvular leak closure. Okay, a very common question I get asked is, how do you size plugs for the device? How do you size the plugs for the defect? So this is a case example. You've seen this already, where we have a mitral bioprosthesis, and there's a long linear defect by the sewing ring. The first thing I would say is we do not measure the width of this. It's really not helpful. What we measure is a rectangular area that encompasses all of the leak. In this case, let's say this was 12 millimeters by 8 millimeters. So we measure from the middle of the sewing ring to the left atrial wall, all right? And then we can cover that entire area with 2 plugs. So for this particular case, I used 2 10-millimeter devices placed side by side that completely obliterated the leak. So as you can tell, it doesn't matter if this is 2 millimeters or 3 millimeters or 4 millimeters wide. We will never put a 4-millimeter plug. We will always cover this entire area with 1, 2, 3, or maybe even more plugs as necessary. So this is a case example of a 69-year-old man who had had a mitral valve repair with a ring and now came back with this massive jet right there of paravalvular leak. And he came to the catheterization laboratory where we got this beautiful image with real-time 3D transesophageal. You see the ring, you see the repaired anterior leaflet, and right here below it, there's a hole. There's an anatomic defect exterior to the ring. So we first catheterized this with a wire and then put a catheter on top of it. And with a TEE, we can immediately tell that we are in the correct position and we're not through the valve. And then through that catheter, I'm putting this AVP2 device. You see we've extruded the distal retention disc. And then as we pull it back, we then release the proximal retention disc, completely sealing off the leak. So in this leak, which was a round defect, a single plug took complete care of it. So this is a relatively straightforward leak as these go. And this is the final anatomic view. You can see the AVP2 device has completely covered the defect. It is not touching the valve. You do not want these plugs to be touching the valve, otherwise the leaflets will deteriorate over time. We can also treat multiple defects. This is a patient that came in with severe pulmonary edema into our coronary care unit, and she was found to have multiple defects around her mitral valve. We took her to the cath lab and placed 3 plugs, and this is a very, very important thing to do, in my opinion. Measure the left atrial pressure through the procedure. So at baseline, the left atrial V wave was 60 millimeters of mercury, 60. And that's why she had such terrible pulmonary edema. Once we put 3 plugs in, look at this. The left atrial pressure almost normalized, and the V wave is now less than 20. So this patient, if they're an outpatient, will feel better immediately. That day they will notice a difference. And if they're intubated in the ICU, we were able to then get her off the ventilator and actually went home a few days later. You can see immediately there was improvement, and with Lasix, we were able to take off the remainder of the fluid. Now, this is a problem that we encountered early in our experience. You can see we're using a muscular device here. We're putting this round device into this linear defect, but there's still a significant gap that is uncovered. And this is how we gradually learned using a single large device is not a good technique. So you can see residual regurgitation around the device can be very problematic. And here's the problem. We're trying to put in a round device into a crescentic defect. And because of that, one device is almost always never adequate unless you have a nice round device. And I've shown you this already, how we actually do the sizing. And here's an example of the simultaneous deployment technique. This is a mitral prosthesis, a TEE probe, pacemaker. We're in the left atrium here with two coronary guiding catheters, two 6 French guiders, and through the guiders, we are going to be placing plugs. Hopefully this will play. Oh no, it's not playing. Anyways, we place two plugs into the defect simultaneously such that they completely cover the defect and do not interfere with the normal motion of the tilting disc mechanical prosthesis. So this is an ideal placement for an anterolateral leak. This is the technique that we use most commonly now, and I was discussing with our colleagues why this technique is so good. It's a complex slide, but here's the mitral prosthesis, pacemaker, and we have created an arteriovenous rail. So this black line here is a wire that goes through the defect, out the aortic valve, and then down the descending aorta, and then we pull it out the femoral artery. On top of this wire, we can then place a delivery system like this shuttle catheter, and through the shuttle sheath, the first AVP2 device is going in. We place the first device, then remove the shuttle sheath, leaving the first device on the cable, and then on the top right, you can see we have gone back in on top of the arteriovenous rail and placed a second AVP2. And then we've done it a third time. And here they are after release. So using the arteriovenous rail technique, we can very quickly place 1, 2, 3, 4 plugs in a matter of a few minutes and then assess the result. Until the very end, everything is reversible. Like even after placing 3 plugs, if we're not happy with it, either from the efficacy standpoint, in the sense that we have failed to reduce the regurgitation adequately, or the safety standpoint, in the sense that we are interfering with the mitral prosthesis, we can remove these plugs. So everything is completely reversible till the very end. And so now this is our preferred technique for complex mitral paravalvular leak closure. Okay, what about aortic PVL closure? We have developed, and others use as well, of course, very analogous techniques where we go retrograde up the aorta, pointing down to the valve. We place a wire through the defect, followed by a catheter. Then through the catheter, we can place a plug. We can even leave a wire in the left ventricle that we term an anchor wire, so we can go back in and do multiple plugs. I would like to draw your attention to the fact that the grading of aortic paravalvular leak is extremely challenging. And the reason it's challenging is that color flow Doppler can be very misleading. Even a small aortic paravalvular leak can have a big color splash because of what we call the garden hose effect. Like putting your thumb on the end of a water hose, you can get a high velocity jet that creates a tremendous color splash, even if it's low volume. So that's only one aspect of grading for aortic paravalvular leak. We also look at hemodynamics like this, the Sinning index developed by Dr. Sinning, where one looks at the fall and decay of the diastolic blood pressure and tries to relate it to the left ventricular EDP. The lower the diastolic blood pressure and the higher the LV EDP, the worse the aortic regurgitation, of course. So this is a case example of when we've come back retrograde through the aorta. We've cannulated the defect. It's beside this mechanical prosthesis, and there's a mitral mechanical prosthesis. And now we're releasing the proximal part. You can see this AVP2 is nicely conformed to the left ventricular outflow tract. The actual defect, it fills in the defect, and the proximal retention disc is below the left main coronary artery. And these procedures are greatly facilitated by the use of computed tomography CT scanning beforehand. We do CT analysis, particularly for all of our aortic leaks, less so for mitrals, but for aortics we do, and then we spend a lot of time analyzing these scans and identifying the actual defect. So here you can see on the posterior aspect of this mechanical aortic prosthesis, there's this C-shaped, G-shaped defect, and here it is angiographically, it looks identical. So we set up the camera angles to match the CT angle, and then we can quickly cannulate it and quickly plug it, as you can see, as we have done here. This is with a small mechanical device. Okay, post-TAVR paravalvular leak used to be more common. With the newer generation of devices, it's now rare to have moderate or severe paravalvular leak following a TAVR procedure. But this was our typical approach. This is with a sapien prosthesis. We put a safety wire through the valve just in case we move it or dislodge it. We don't want it to embolize. So we put a safety wire through the valve. Then we cannulate the leak. And in this case, it's looped back out the aortic valve. And then we can put a catheter over top of the wire. And then through that catheter, we go ahead and place, in this case, an AVP4 device. The other thing I would caution is we must be ready to remove what we put in. So this is an example of where a device embolized. The good news is they typically do not embolize to the carotid arteries and almost always get lodged in the common iliac right at the site of the aortic bifurcation. So structural operators who are doing these procedures must be ready to be able to remove these devices like we did here, goes right back in. So using snares to create AV rails or to remove plugs that have embolized is very important. Now, how do these patients do? We have published a large number of papers on this procedure looking at outcomes, and I would like to make some important points. The first thing is, and this is from our practice by my colleague, Dr. Al-Khuli, that optimizing the procedure by reducing the residual leak to almost zero is the goal. The lower you can make the residual leak, the better your patient will do. So in this example, as you can see, out to 100 days or a few years, 4 years, if patients had only mild residual paravalvular leak, they actually did very well in terms of rehospitalizations or repeat procedures. But if they had moderate, then of course, they'll need many more procedures, including redo surgery. As I've already mentioned, measuring the left atrial pressure is an important hemodynamic correlate of success. So we really feel that if the final left atrial pressure, okay, can be reduced to less than 30% of the mean blood pressure, these patients will do quite well from a survival standpoint and from a rehospitalization standpoint. But if their left atrial pressure remains elevated, they will be back. And sometimes the pressure will remain elevated if the left atrium is stiff and non-compliant, and then we can't do much about that. So just to reiterate, our goal is to place the plugs precisely in position and to have no regurgitation if possible. There's a big learning curve with this procedure. Of all the structural procedures that I do, TAVR, mitral clips, left atrial appendage closure, etc., these are by far the most complex procedures. And as you can see, the procedural time gradually fell from almost 3 hours in the first 50 cases. And now we can reliably close even the most complex mitral paravalvular leak in about an hour. So there's an important learning curve. Similarly, the rate of adverse cardiac events has fallen significantly with experience. It's now down about 4%. And most of those adverse events are actually bleeding events. And so we have to be very careful with anticoagulation management. So I tell my patients that now the chance of having a successful and uncomplicated procedure in experienced hands is about 90%. So we think that's a reasonable number for such a complex structural heart procedure. There have been many outcome data. This is a meta-analysis produced by my friends and colleagues in Canada. And what they showed is that with successful paravalvular leak closure, cardiac mortality is reduced, functional class is improved, and the need for repeat surgery goes down markedly. So these procedures do work and to provide significant benefit to a very high risk and a very complex cohort of patients. So, what can we conclude? Number one, paravalvular leak is relatively common and underdiagnosed. Two, endovascular or percutaneous closure is feasible, but there's a significant learning curve for new operators. Three, residual regurgitation is the key determinant of outcome, so procedural optimization is very important. Four, paravalvular leak closure improves symptoms, hemolysis, lowers the need for subsequent surgery, and is associated with lower mortality. Very important patient benefits. So with that, I'm going to close, and I will be ready to ask any questions that the group may have. And I hope this is something you never encounter. So thank you all for your attention, and I look forward to chatting with you further.
Thank you very much, Professor Chet. Fantastic lecture. I'm going to open to the question, but at first, I'd like to send a big hug from our colleagues from all over the world. We have our friend Mizuki from Tokyo, Julio and Daniela from Rome, Sebastian from Argentina, Ana Tagliari from Zurich, and all of our colleagues from Brazil. And I would like to start to invite our colleagues to open your mic and do some questions to Professor Chet. Max, Edgard, Pablo, Felipe, could you open your mic? And Max, do you going to start? Are you going to start?
Yes. First of all, congrats about the very important lecture. It was amazing, clear, and go to the point, exactly the point. The first question is about the problems that you have in the United States about just the unplastered devices, including the vascular plugs and then the ASD and PAD devices. What's your opinion about the new devices that you don't have but are going to have in the United States, the ventricular septal defects, and that your opinion about the quality of the net of the device provoking or develop the complication that is the hemolysis after the procedure due to the device?
Okay, thank you for your question. So firstly, I don't see it's a major problem. With the AVP2 devices, we can close almost all the leaks. Every aortic, every mitral we can tackle, pulmonary tricuspid we have done. I don't actually see it as a major problem. I think the AVP2 device is an excellent device for these procedures for the following reasons. It's malleable, soft, has thin braids, it's almost like a fabric. And you can easily put multiple devices to fill up the nooks and crannies. So the new devices, I think, have a lot of promise, but they will have to prove that they're better than the AVP2 in my mind. And so I want to get away from us thinking that there's going to be one device that will solve everything. I don't think that'll happen. I think the Occlutech device has really a lot of promise, particularly for rounder defects. Even the AVP3, which you may have there, which is the oval shaped device, I think can be very useful, particularly for mitral paravalvular leak. But my colleagues in Europe who've used those say even they will sometimes have to use more than one of those. So I don't believe that any one device will solve all these problems. And so we'll have to see. I'll have to try them and see.
Perhaps the characteristic that we are looking for in a special device is exactly like a woman looking for a husband.
Difficult to find.
You can find everything. You can, or you are going to have a characteristic or something forward, another against.
Thank you, Max. Pablo, Felipe,
Professor Chet, one question, please. First of all, congrats, and we thank you so much for your your kindness to be here with us. And it's been a really great time to see you and to hear you and teaching us. And my question should be about the access. I know there are some groups that favor the transapical approach, and others they prefer the transeptal. So when you see that you have to choose one or other way to go, let's say like this.
Thank you for your question. I don't think it's a question any longer. This was a question about 10 years ago we used to wrestle with. Now it's not a question in my mind. So when we first started doing this, I'll tell you how it went. We thought that transapical might be good for medial mitral paravalvular leak, right? But when you actually do it, it's not so easy. You put the catheter in the apex, moving it is not so easy because the heart is this thick and the heart is moving. Grabbing your catheter is not so easy. Plus, you're sticking the apex. And you can look it up. We published a paper on like 3 dozen transapical approaches, and there's a significant incident of hemothorax on the left side, even if you close the apex, because there's usually veins, there's a plexus of veins around the heart that can bleed. So originally, I was doing about 10%, 15% apical access. Now it's 0. So the only time I do apical access is to make a rail. If I have 2 mechanical valves, aortic and mitral, and we cross and I need a rail, then we can do a small puncture in the apex, grab, snare the wire and pull it. But I can tell you, once you learn to use the flexible catheter in the left atrium, you can cross every mitral paravalvular leak, medial, anterior, posterior, lateral. You can learn how to cross them using echo guidance and fluoroscopic guidance. And I personally do not believe that we need to even think about doing transapical access unless in a very, very rare situation.
Thank you so much. And what's the tip to enter in the septal leaks? If you have some tip and trick to enter, because we feel that the paraseptal are the most difficult to access by the transeptal.
Yep. So I agree with that. The transeptals that we do for these procedures are the most difficult transeptals because the septa often have been opened, patched, closed, calcified, fibrotic. So you need to have many tips and tricks on how to cross the septum. So number one, you want to cross the septum in a posterior angulation. You want your needle pointing towards the spine. If you're pointing towards the spine, you'll go posterior, and then you will have enough room to turn anterior, right? Because the mitral valve is going anterior, the septum is going then you have to be able to turn. So you need to point posteriorly, right? So I have a whole stepwise gradation that we use. Start with a simple needle. If that works, fine. If it doesn't work, we put the safe sept wire through that. If that doesn't work, we electrify the needle. You take the electrical bougie from the operating room, touch your needle, bzz, it'll go right in.
Yeah.
If that doesn't work, you can use a radio frequency needle. They're very expensive. I don't think you really need them. But using these tips, you can always get in, unless the septum is heavily calcified. So you may have a congenital heart disease patient who's had 5 operations and the septum has been accessed 2 or 3 times. They can get calcium, and the calcium you cannot penetrate. So then maybe think about transapical, but that's very rare.
Okay.
Does that help?
Professor, we have many questions from our chat, and Ricardo is asking if you could tell us a little bit more about having 2 plugs or 2 catheters through the holes, through the defects, and how do you manage this?
Yeah. So there's a number of ways to do this. I'll give you 3 different techniques. One is a simultaneous deployment technique, right? You cross with a wire in the catheter, then you put a second wire in there.
Yeah.
Then you take out the catheter, then you put in 2 catheters.
Yeah.
And then you put in 2 plugs, okay?
Okay.
So you can do that.
If you can interrupt just one moment. First, you get through the defect with the wire. Then you put, for example, a guiding catheter or
Yes.
an angiographic catheter. And do you use this catheter to put 2 wires at the same time?
Yes.
Okay. Then you pull the catheter off.
Yes.
Put it in again in only one of the wires.
No, you put 2 catheters. You can put 2 catheters in.
Okay, at once.
Okay. So that one is called the simultaneous deployment technique. But honestly, I don't use that very much. The best technique I feel is to create the rail, to put the wire in, send it out the aortic valve, snare it, and pull it out.
Yeah.
And then you can use that rail to deploy many plugs.
Is this technique used mostly in mitral paravalvular leak? Okay.
Yes.
And to the aortic paravalvular leak, you most of the times you might use the retrograde technique. Okay.
We use a retrograde technique, and if you need 2 plugs, you can leave a wire in when you put the first one. So you can put like a 7 French guider in, put the wire, leave it in the left ventricle, put the plug in, beside the wire, right? And then you can take out the catheter and go back in. So that's called the anchor wire technique.
Yeah.
So 3 different techniques.
When you use more than two or more devices at the same time, you use a 8 French sheet.
Oh, in the femoral artery or in the femoral vein, you mean, or
to deliver the devices together?
No. We don't deliver them like that. We deliver them one at a time. So you create the rail, right? Then you go with the delivery catheter, put the plug, it's hard to describe, right? Take out the catheter, go back on the rail, put another plug, take it out, go back on the rail, put a third device. It takes 5 minutes.
So sorry, Professor, that we were discussing this offline, and that's a brilliant tip that we couldn't understand. Is that when you do this by the vein, you have to put a 14 French guide or sheet in the vein, and then you can put up to 3 guiding catheters or sheets inside the 14 sheets. That's very important to explain to the audience.
I will tell you that we wrote all of this up, and I believe it was in JACC, Journal of American College of Cardiology, a few years ago. My partner, Mac L. Eid, is the first author, and I'm the senior author, so you can look it up. It's called Procedural How to Do Paravalvular Leak Closure. So we describe all of these techniques in there. And maybe we should update it and make some videos now and put them on YouTube rather than putting them in a journal.
Before Pablo
excuse me. Professor, thank you for your great lecture. And I have 2 questions. The first one, which would be the first choice of guide wire to establish the AV rail and maintain access during the deployment of these multiple devices? And the other question is, talking about sizing and planning of the procedure, should we have a CT scan of every single patient with mitral leak, or it's not necessary?
Okay, great questions. So the first one, in terms of the wire, I prefer to use hydrophilic wires. I believe they're safer. And so I like to use the stiff angled glide catheter made by Terumo, not catheter wire, stiff angled glide wire made by Terumo. It's a very nice slippery wire. The tip is very soft, just angled, but the body is there. It's relatively stiff. So you can wire it, you can loop it on the apex, and then send it out the aortic valve. It's very safe to use. You won't perforate the apex. And then it's easy to grab. It gives you a nice rail. You can use 035 or 032. In some cases, if it doesn't make the loop, you can use a regular stiffness hydrophilic wire. But generally, the hydrophilic wires are best for the initial cannulation and then creation of the AV rail. Okay?
Okay, fantastic.
Yeah.
We need to move on. Pablo, could you start to share your screen? But I think that we have time to one more question while Pablo starts his screen sharing. And do you have any question more, Quintella?
Yes, there's one more question from Sebastian Peralta from the chat. And he's asking to the professor if the paravalvular leak is placed in the mitral aortic junction, causing a rocking valve. Would you recommend a TA approach?
No, I would not. No, I would not recommend a TA approach. I would do a retrograde, and you should be able to close it that way. If that doesn't work, then you can do a TA approach. But generally, you should be able to close this either retrograde transaortic or even antegrade left atrial. And we've had a couple of cases like this where we put the wire through and through beside the mitral valve and then loop it out the aortic defect.
Okay. Okay. Thank you, Pablo. Could you start your presentation? And during this presentation, you can interrupt Professor Chet or our other colleagues to ask something, to say some tips and tricks. Feel free to interrupt when you think it's important. Okay, Pablo, please, you can start.
Your mic is off, Pablo.
Okay, can you hear me now?
Yes, very clear.
Okay. So sorry about that. I'm just going to share my screen here.
While you're sharing your screen, Professor, I see you have your most major preference for the AVP2 device. At the beginning, when I started seeing paravalvular leaks, I thought the main tool that would be the best to use was the AVP3. Is this wrong, or do you think the AVP3 is a good tool also?
I believe it's a very good tool. The issue is we don't have it in America. Our FDA has not approved it yet. So if you have the AVP3, I would use it.
Okay. Can you see the screen?
Yes.
Okay. So let's go. Let's do this now. Thank you, Márcio. Thank you, Edgard and Gustavo and Paulo and all the guys. As you can see, it's a beginner's perspective. So I assume that we have made a lot of mistakes, and that's why we are here. And we are trying to get information and share and get information from the experts. So this is our team. The operators, I always start with Max because without him, impossible to do this. And all the guys in anesthesiology and nursing management and the guys and the operators as well. So nothing to disclose with this presentation. I'll start with the clinical features. It's a female 73-year-old with rheumatic fever and mitral stenosis and she had her first surgery in 2004 for a bioprosthesis, and then she had a breast cancer with radical mastectomy in 2009, chemo 2010, and reconstruction with a latissimus dorsi muscle. 2012, second surgery for a bioprosthesis failure, and 2017 started AFib with warfarin, and she started then, I assume that was the problem with the hemolysis for the valve, for the leaks. Enemy with a not discovered etiology because they were looking at the GI bleed mostly. And so in 3 years, she got worsening of symptoms, and in the beginning of this year, heart failure class 4. And then we have these images in the TT echo, the evaluation with a huge leak in the anterolateral aspect of the atrium, of the left atrium. So the CT scan that we got, a very complex anatomy with lots of serpiginous traject, and that's my first question to Dr. Rihal, if he can say to us, this kind of anatomy, do you feel it's only one hole with lots of trajects, or there are multiple? Because I can understand this anatomy very well.
So this is a great question, and usually the anatomy is very complex, is very serpiginous, and usually there's more than one. And by the way, I think you're lucky the CT scan showed it so well. Often the CT scan doesn't show it so well because of blooming artifact or missing it. And so we rely a lot on 3D transesophageal to locate the mitrals. For the aortics, we use TEE much more. That's point number one. Point number two, the serpiginous anatomy is one reason why I favor the AVP2 device. Okay? The AVP2 device can be stretched. It will stretch and it will fill. It's ideal for these serpiginous defects. The thicker braid devices like to be round, and this is not a round defect.
Okay, thank you. And so Dr. Chet just showed this slide, so showing how it's not closing an ASD because it's not round. It's so complex. And this is the echo image of the pre-procedure showing
atrial appendage.
Yeah, Max, do you want to make some comments on this anatomy?
Yes, because that's the Professor Chet said. You have to use the anatomical references, and here you have a very huge left appendage and a circumflex, and you have to see that you are not at the center of the maximum diameter of the prosthesis. We are coaxial to the prosthesis. So here we are at not exactly at 9 o'clock if you are looking at the clock references. And this is very huge in an anterolateral position. That's when we started to fix the problem.
It's a very common location.
And let me say one question. Looking this movement of the prosthesis, you can think that the prosthesis is unstable or not.
Yeah. I mean, these will move. The bigger the leak, the more it will move. But you're not going to rip it out of there.
Okay.
And actually, once you put the plugs in, you will stabilize that motion.
Oh, great.
So so I wouldn't. You have to be careful, of course, but you're not going to pull the valve out of there.
Okay, great.
Yeah.
So can I move on, guys?
Yeah.
Okay. So planning the procedure, Dr. Chet just showed us. So I have to spend some time talking about the toolbox. It's very important to have lots of tools to do this. So I start with the regular sheets for the puncture of the artery and veins, the hydrophilic terumo wire, as Professor Chet just said. One question is angulated or straight. I think he told us the angulated should be better. Pigtail, the diagnostic catheter, just like JR and Vert and Berenstein. The transeptal needle, 1, 2, a Mullins, regular sheets, and very important. I think it's a paramount for this procedure is the Agilis sheet because it's deflectable. Without this sheet, we can do this procedure. We think that's impossible to do this. So the extra stiff wire, Teflon, the regular one, the Lunderquist double curve wire. We use this because it's cheaper than the Safari or Confida wires. and it gives us strong support to cross the leaks when they are serpiginous. And sometimes it's really hard to cross it because it's very resistant to passage of the sheets. We use sorry, please go on.
Yes, thank you. So I agree with your point that these leaks can be extremely difficult to cross. And that's the reason we make the AV rail. Once you make an AV rail, if it can't cross, you simply pull on the rail and it will cross.
Okay.
Yeah.
So we have to use the long sheets as well, or the guiding catheters. We think we are using the shuttle sheets as from Cook because it's highly hydrophilic and helps a lot. Once we had a case that we used the Raabe sheet. It's not hydrophilic, so it was very, very difficult to cross. So I strongly advise you to use hydrophilic sheets to cross it.
Yeah.
So the M-Platzer vascular plugs 2 or 3 and ProGlide or angioceus to close the arteries in the end. Snare is very important. We have here in Brazil the one snare that's one single loop, and the end snare, the 3 loops from Merit. It's very. I think it's much easier to because you have 3 snares to grasp the wires. We don't have to forget the pericardial draining kit or something that we can make it home. The muscular VSD, interrogate that. We just had a talk about this, and some angioplasty balloon for dilatation of the atrial septum. It's very important to have, as Professor Chet told us, because of the calcification, multiple surgeries, a fixed septum, etc. So the procedure was made by general anesthesia, the echo, transesophageal. We had venous and arterial access by femoral approach. So what we were discussing how to do this presentation, and me, Felipe, Dr. Gubolino, and we just saying about making in steps. So you can interrupt me anytime in the steps and explain what you could do, or what we should have done, for example.
Okay. Just for me, Pablo, that question, before you start the step by step, it's great to discuss this. I'd like to say that we have some doctors from Turkey, from Online Cardiology Club. A big hug to my friend Sercan Okutuku from Ankara, and Dr. Niazi from Pakistan. We have doctors from all of the world watching us.
Wow.
Can I go on?
Yeah, please.
Okay. So step 1, transeptal puncture. Pitfalls, LA dilatation that may distort the anatomy. So sometimes we can find the septum very, very easy, just like made a regular transeptal puncture, and thick septum for multiple previous interventions. The patient had a complication, an AV block soon before the puncture, the septum, and we have to put a pacemaker. So this was the approach. We tried to use a regular Mullins sheet, SL1 from Abbott, but we just couldn't reach it because I think it was posterior and distorted to the right. And so we had an idea to use the Agilis sheet, and I had a brilliant idea that wasn't brilliant at all, to deflect the sheet to move it posterior. So just like bending the needle, but what I did was to deflect. And what I did at this point was to break the deflectable system, and so we damaged the sheet. So I think it's not advisable to do this.
Can I make?
Yeah, please.
Okay, so just a couple of comments. This looks like a very difficult transeptal, but you see how close it is to the aorta? I think it's personally, I would advise this is too anterior. So remember, the left atrium is not a left atrium; it's a posterior atrium.
Atrium, yes.
Yeah, and it goes from the right of the spine way to the left. So personally, if I'm doing this case, I point my needle to the spine, straight posterior, and we double check with echocardiography. Usually it's inferior posterior, and then you have more room in the left atrium to work.
Yeah, this is a good vision. I've heard this at first time from Dr. Mohamed Saraf from Alabama, and he has told me that there is no left and right atrium, but we have anterior and posterior atrium. And we know that the ageless catheter has small, medium, and large bands. Not band, but the size of the curve. Do you have any preference for the small, medium, or large?
Yeah, I always use a medium unless it's a medial leak. If it's a medial leak by the interatrial septum, then I use a small curve, and that's it. Very simple. Great. Very simple.
Great.
Yeah.
So what I had to do this here, if you can see, we're tenting the septum, but it won't go. So we had two options here, or using the back end of a 14 wire regular from angioplasty to cross it.
Yeah.
But we prefer to use the electric scalpel and just using the power to 30 watts, I think, and just touching the end of the transeptal needle, and we could cross it easily, very easy.
If I can ask, I want to make one other point about working in the left atrium. So these are difficult, long procedures, and there's a risk of blood clots and thrombosis developing. So what I advise, and I don't know what you're doing, I give 200 units of heparin per kilo. So that's much more than we give for angioplasty, but this is not angioplasty. And remember, in the operating room, they give even more. So I think if you give 200 units per kilo, it'll have a very safe procedure, less likelihood of a thrombus developing.
Yeah, this is a huge cavity with low flow, and you can have clots inside the
yes.
Yeah, that's it.
Okay,
so you use all the dose before puncture or half and a half?
I give about 3,000 or 4,000 before the puncture, just to make sure the transeptal needle or catheter doesn't get it. And then once we do a puncture and our echo colleagues confirm we're in the right position, then I give the remainder of the dose.
Okay, great.
Thank you.
Very nice. In this case, we gave her 2,000 and 2,500 before punching, and then more 5,000 units, and so she was 50 kilos, so it was 150 units per kilo, and then check it with the ACT. That was our approach. So we created a problem here because we didn't ask the supplier backup Achilles sheet, so we just had to do a second one. Unexpected problem in this case, the malfunction of the 3D echo probe, and we had to rely on the 2D echoes instead. So how we managed to cross the septum? It was a very thick, 2 previous surgeries. So we placed a stiff wire, a Teflon wire, in the left upper pulmonary vein, and we pre-dilate the septum with a regular OTW balloon, 10 to 14 millimeters, just to open the way to the Achilles sheet. That's the image here. So you can see in the left side, that's very, very resistant septum, and just we didn't fully open the septum, just to open space to work with the Achilles sheet.
Yeah.
So a couple of other tips and tricks.
Yeah.
So I used to do this approach, but what I like to use now for wire in the left atrium is the Inoue guide wire. from the mitral
okay.
valve. You see, because it has a nice curl, it's very safe, it's stiff, and it's strong. I have noticed with these wires going on the left upper pulmonary vein, sometimes they can get into the appendage, sometimes they can cause hemoptysis. You have to be really careful, but the Inoue guide wire, extremely safe in the left atrium. And then you can use the dilator from the Inoue kit just to open the septum.
Okay, great.
Very nice.
And
The
Pablo,
just to clear,
we have-
Pablo, we have had problems with the TD broad or the board on the equipment, not the image at all. The 2D image was sort of okay, just the TD broad.
Okay.
Yes.
And now we have Dr. Jalal Sayed from cardiac surgeon from UK watching us.
Oh, good morning.
Let's go, Pablo.
Okay, so step 2, finding the hole. We deflect the Agilis sheet, rotating the control knob clockwise. That wasn't available at the time. So we use the telescopic system, for example, a diagnostic catheter, a JR of Vert, to find the hole, and use a hydrophilic wire to slip through the defect. That's in the images here. So you have on the left-hand side the Agilis, diagnostic catheter, and the wire, the hydrophilic wire. You see, when you look at the RAO projection, and the anterolateral leak, it's up to the right-hand side of the mitral annulus or the valve annulus.
And it's far from the spine, huh?
Yes.
The anterolateral, huh?
Mm-hmm.
And see, it's far from the spine. I think that's anterolateral hole. The approach, if you don't have a ageless catheter, that I know that's more difficult when you don't have a catheter. But you can put Judkins right or internal mammary catheter, try to cross. I think it's a good idea.
Yeah.
So step 3, advancing the diagnosis catheter into the LV and place the wire in the aorta for support and stabilization of the system, or creating a AV rail, as Dr. Chet taught us. So that's what we did. Nice. And advanced the diagnostic catheter and in the apex of the ventricle. Step 4, remove the hydrophilic wire and leave the catheter into the LV, and exchange the wire for a supportive one, in this case a Landerquist, and then leave the DC wire, exchange the Agilis for a hydrophilic long sheath, in this case a shuttle from Cook. So you can see here, we exchanged the catheter that there's in the right-hand side, a 6 French shuttle, advancing into the LV with the Landerquist protecting the LV. And then implanting the plug. What they did, we chose first a 10 millimeter because it the measurements were about 6 or 6 millimeters. We placed as a 014 wire for a regular one for angioplasty, a safety wire in the LV. So if we lost the position, we could re-enter the hole without having to start all over again. We loaded the plug in the delivery sheet and released the LV disc, the first disc from the AVP2, and gently we pulled until felt resistance. As you can see in the right panel, right image, there's the disc just touching the hole, and you can see the constraint here, as Dr. Chet told us, because it stretches and it can conform in the anatomy of the leak. So this is the image that we see when we retract the system. So in the left panel here, we have the LV right here, the disc, constraint in the leak, and in the left side we are in the atrium, in the left atrium here, the other disc. and the cable. And that's in the right hand side. We can see the plug here in the echo, how we can and see it in the echo screen.
Okay.
So we ready them and release just in the rotating it anti-clockwise, the cable, and releasing the first plug. Okay, we at this point there's a lot of shunt here, so we had to approach the second leak. But the image that we saw that it was posterior, just like 6 o'clock in the image of the surgeon's view, or posterior, and we could, as we lost the Achilles, we have to do a retrograde approach. So what it did, we placed the Simon's 1 catheter in the LV and tried to point to in the RAO projector or in the LAO to look if we could cross retrograde. And that's what he did. We with the Simons in the hydrophilic, then we created sorry, please.
Chet, what do you think about this retrograde approach by aorta to the ParaValvular PVL in mitral?
Look, I think it's a good backup approach. So we first do antegrade transeptal. If that doesn't work, then we do a retrograde transaortic. I mean, congratulations, you made that look easy, but I don't think it was so easy. It's a really nice, tricky, right? And then the third approach we use is transapical. So it's a good approach, but you just have to, it's not so easy to turn the catheter posteriorly. And sometimes I find to use a GR4 or a left coronary bypass catheter, it can also work.
The advantage of this way is that you don't have to worry about corda because you are a prosthesis, and you are to the flux for the flux, so the regurgitant flux. So if you use a hydrophilic wire, you are going to the flux.
Yes,
yes. The flow from the left atrium and not to against the flow.
Yes,
that's it. Move on, Pablo.
So, okay, you can see here, and the echo image shows very well the wire passing through the leak. That's very important because when we do this, we have to have in mind that the easiest hole to pass through is the valve. So sometimes you think you are in the leak, but you just pass through the valve, through the prosthesis, and you are in the left atrium.
Yeah.
So what we did here was to remove the system and just to leave the sheet, and we placed a angioplasty guide wire, a 014 wire, and then we released another plug that's an AVP12, and then release it. And you can see here that in the end of the 4-hour procedure, very, the patient was unstable on vasopressors, and we still can see here another leak.
Yeah.
It's
a splash, as Professor told us before. Huh?
Yeah, this kind of leak takes 2 or 3 plugs usually.
Yeah. So decision was 4-hour procedure, AV block, unstable, no vasopressors. We decided to stop and watch. Initially, we had a good recovery. The patient went to class 4 to class 2, but 1 week after the procedure, worsening of symptoms, fatigue, dyspnea, anemia, and blood transfusions. 4 blood transfusions in 4 weeks, 1 per week. She was losing 1 point of hemoglobin per week. So we made a new TT echo, and you can see here on the right side, left side, lots of plugs there, but a residual leak, and the jet, very a mosaic there. Please, someone want to talk?
No, so we started with a very, very huge amount, and now we are just a huge amount of regurgitation.
Yeah. So, and just a word about hemolytic anemia, because we had some trouble here. We had to discuss with the hematologist to learn how to manage this. So we had a drop in hemoglobin levels. We have a rise in lactate dehydrogenase up to 3,000, very high. Rise in reticulocytes, the highest value 2.8, and the normal is 2. And a drop in haptoglobin levels. It was undetectable at the time, and quite normal bilirubin. So with this, we had to make something for the patient. So we planned a second procedure 1 month after the first one, and she was more stable. But the AFib, we used the same toolbox, but this time with backup sheets and wires. So we learned. So we managed to use the hole that we did in the first approach, and we did it, although it was small, as you can see here. So we passed with a hydrophilic and then dilate the septum with a regular dilator of the Agilis sheet. And now our life got better.
Pablo,
sorry.
Did you use the same hole of the first procedure?
Yes.
In transeptal? Yes? Okay.
Yes.
Okay. Yes.
So our life got better because we had the 3D. So you can see here. Can you see the marker, the pointer?
Yep.
We could see a small hole between the two plugs, the two previous, and a big one here in the posterior view.
But now you turn on the lights on the room with 3D.
Yes. Can you see the image?
Yes, beautiful.
Yeah.
Okay. So when we saw in the 2D, that how it looked like so, and but this time it was much more easy because we had the Agilis, we could deflate it. And as Max told us, that was a reference because we could see the two plugs in the fluoro, and we could see it on the 3D, and we could see, as you can see here, the Agilis sheet coming through the septum, and we pointed to the small hole. Okay. So basically, the approach was the same: make a rail, pass with a Vert hydrophilic catheter. And some colleagues, when I showed to some colleagues, they just asked me, weren't you afraid to cross two plugs implanted in a month ago with this catheter? That was one question that I heard. But to be honest, they were very, very tight, stable, very stable.
Excuse me, Pablo. Professor Rihal, can you give us one or two tips to understand a little bit more, looking through the radioscopy, as if we can have some marks to help us to guide.
Yes. So that's a great question. And I think you're using primarily, it looks like an AP view here, a little bit LEO. I think the two major views you should use are LEO caudal, looking up at the valve. So you see the valve in a nice circle, okay? That's like the first view.
Like on face.
En face. And then the other view you should use is the orthogonal view in the REO view, where you're looking like this. And then you can see how your plug is fitting across it, right?
Okay.
So I don't use AP view because the AP view is not orthogonal. You need en face and an orthogonal REO that shows the atrium on one side and the ventricle on the other side.
Okay, good.
Plus, as you know, for the mechanical mitral valve, you have to pay very close attention to the motion of the valve. So you have to set up your camera so you can visualize that motion.
Yeah. Okay.
Okay.
I don't know. I don't know if you have biplane fluoroscopic lab or not, but if you do, it makes it easier, I think, a little bit. Yeah.
No biplanes. No biplanes.
We don't have cameras here. Yeah. Most of the cat labs.
Yeah.
So this is the release of the third plug that was a 6 millimeter between the two previous plugs implanted. And then the more difficult one was to find the big hole, because it was posterior inferior, and then we used the projection, the LAO cranial, just like the 4-chamber view. I think it was it helped us a lot.
Yep.
And then we cross it, as you can see in the left hand side. Made the same. And at this point, as you can see, with a safety wire and releasing the fourth plug, as you can see here, in the echo image in the left-hand side. Lots of metal there. And then I think it's the releasing the fourth plug.
Very nice.
So this is the final angel. Just showing the 4 plugs in position, and the beautiful image of the 3D echo showing the 4 plugs. So we got more than I should say 40% of the circumference of the annulus. And the final decision was to exclude the thrombus on echo, on the LAA, and to cardiovert the patient to achieve sinus rhythm. And she was discharged at day 2 after procedure, and had a substantial clinical improvement. Her hemoglobin levels up to 11.7. She's 50 kilograms, so I think it's fine for her. And reticulocytes down to 1.8, and she's now in class 1 heart rate failure.
Pablo,
sorry.
Excuse me for a while, just to ask a question to Dr. Rihal.
Sure.
You commented about the circumference of the defect. And Professor, what would be the maximum circumference of the defect that would represent the limit for a contraindication of the procedure?
So, it's a good question. If it's 50%, we will not do it. But if it's 25%, we will do it. So, if it's 30, 40%, if the valve looks stable and there's no active endocarditis, we will still do it. And you can put in multiple plugs, will stabilize the valve. So I just want to say congratulations. This is a very difficult case. I think you did your patient an excellent service. The only, what I'm going to say now, the only suggestion I have is when you learn to use the AV rail technique, then on the first go around, you can put 4 plugs very quickly. It will not take you 4 hours. I can tell your team is highly skilled. And once you adopt the technique, you'll be doing this case in 1.5 hours.
Thank you, Professor.
The whole thing. Yeah. So congratulations on that.
That's the we were discussing with Márcio.
You will.
We were discussing with Márcio first, and Max and Felipe and all the guys. That's the point. We have to learn with more experienced people, and we have to share this knowledge. There's no other way to do this. So I really appreciate your comments, and fantastic. This is the third echo, so we have a substantial improvement, but we a trivial leak, but we couldn't just fix all it. But clinically, it's okay. So the timeline echoes. You can see the first one, left hand side, a massive leak, and then the second one got very better, nice. but not so bright. And in the right hand side, the final results. So it was an entire team. Thank you, guys. It was a magnificent opportunity to learn from the best. I think we leave this session here. I don't have words to express my gratitude to Professor Chet. and all the guys. And I lived our beautiful river, the Piracicaba River, and in the summer season. And hopefully I wanna share this image, and thank you all the guys for this presentation and the session. Thank you, guys.
Thank you very much. I can hear the claps for you, for your team, for Professor Chet, and we have 9 minutes to finish the session. Edgard, could you see the questions on the chat to answer? And if you have some observation to do, the time is now. Max, do you want to say anything?
Yes, I would like to ask about the rail technique. You develop all the four devices, and then you still have the rail. Yeah? And when you take it out, you take it from the artery, because you are going to go through the flux. You are not going to go from the left ventricle to the atrium. So to the atrium, to the left ventricle, and then to push it on that way.
I pull it from the venous side.
The venous side.
I pull it from the venous side, and the reason is when it's coming back, it helps to maybe push the plugs back onto the annulus. If you pull it from the aortic side, there's a little bit of a risk it may get caught in the plugs. There's a less risk if you pull it from the venous side, and then your final step is to release the plugs.
And first you push from the artery and pull for the vein. Pushing and pulling.
Yes.
Okay, great. Felipe, do you have any question for Professor Chet?
Yes, one more question. I would know if there is any advantage of printing 3D models before the procedure. It's an emerging technique.
Yes, in fact, we use 3D modeling quite a bit. Let me show you. So I don't know if you can see on my camera here now, but this is a 3D model, right? So we have used 3D modeling early in our experience to understand the anatomy. However, here's what I will say. The most important 3D that you can do is your transesophageal and your CT scan. So the 3D reconstruction has to be in your mind, right?
Yeah.
You can print it here, but it's more important if you can reconstruct the 3D in your mind. So when you're working in the patient's heart, you know exactly which angle to go. Yeah. So it's a great question, but we don't use this anymore. We used to use the models first. Now we're just relying more on imaging.
Now the image is printed in your brain, huh?
Yeah, that's what you have to do. Yeah.
Edgard, any question for the chat?
Yes, we have questions from the chat, and just to talk a little bit more about 3D models, we are beginning our experience with the 3D models, and I think it has a very good space about learning to view the 3D images in your head, and that's how we plan to use it.
Yes.
And let me go to our questions. I have a question from George Mayo, and he's asking about rocking valve has always been considered a continuation for PVL. Is it no more?
What I would say is it depends, right? There's mild rocking, medium rocking, and severe rocking. So if it's just mild rocking and 80% of the valve is fine, then I don't worry about it. But if the patient has had endocarditis, a 50% dehiscence, and significant rocking, that's a contraindication. So you have to make a judgment call by looking at the valve, and I would encourage you to have your cardiac surgeon look at it as well. Then he or she can look at it and say, gosh, I think this valve needs to come out. So it depends. It's a spectrum, right? Mild rocking is okay.
The rocking valve and the rocking problem, the instability, is much more related to an acute or a short time from the replacement, or it's not common to see at a long time from replacement?
You can actually see it later because people can get endocarditis, or when they get older, right, the tissues become softer and more friable. And then I have seen valves perfectly fine for 10 years, and then they're coming with severe mitral paravalvular leak.
You said about something about corticosteroid therapy.
Yeah,
and you have to take care about starting at corticosteroid therapy in patient with prosthesis.
All I would say is that's been my observation in 1 or 2 patients, that the initiation of corticosteroids was followed by development of paravalvular leak, because I think they cause the inflammation and the steroids cause tissue friability. So
Okay.
I don't think it's a contraindication, but just something to keep in mind.
Okay.
And another question from the chat, Ricardo is asking, for multiple plugs, is the safety wire or the atrioventricular rail, AV rail, the best approach?
Yeah, I in my opinion, the AV rail is the most versatile, safest, and most efficient approach, followed by the safety wire or the anchor wire technique. But if you learn to create the AV rail, it's a very nice approach, and it's not a difficult approach once you learn to do it.
Okay, great.
Yeah,
I think there's more.
There's one last question about Jalal Ben Said from
UK.
His transeptal approach is challenging percutaneously. We talked about transapical, but what about transatrial through right mini thoracotomy? Can this give better option?
Well, I think if you're going to send a patient to surgery, then the surgeon should choose whatever repair or replacement technique he or she feels is best. Usually, if they go to surgery, they get a mitral replacement. It would be we have never done a PVL closure transatrially. Would never had the need to do it or via thoracotomy. So usually, if we're sending them to surgery, it's for a replacement.
Okay. Thank you, Professor. I learned a lot. We have a lot of colleagues here in Brazil, nice, like Diego, Ricardo, Júlio, Andrea, Maurício, Jaramillo, a lot of our friends here in Brazil. I know that it was a fantastic session. It's an honor for us on the 4 channel for Valves TV to see your presentation, your tips and tricks. We need this here in Latin America, and but today for this session happens for all of the world. We have a lot of friends from Turkey, from Japan, from Pakistan, from UK, from Europe, and it's really impressive your kindness, your willingness with us. I would like to say thank you, and if you have one more thing to say, take your time, please.
So yes, thank you. So firstly, it's my honor to be here with all of my new friends from Brazil and our friends and colleagues from around the world. This year has been a very difficult year for our world, right? I wish I could come to Brazil and work with you in the lab side by side. Yeah, it would be so enjoyable, nice for the patients. But I hope that we will have that day soon when we can all travel again to visit each other. And I hope all of you out there are staying safe and you and your families are keeping well. And I look forward to the day we can meet in person. So I wish all of my friends around the world the very best. Thank you.
Thank you very much. It was an honor for us. Thank you very much for all of watching us today. Thank you, Professor Edgard, Pablo, Max, Felipe.
Thank you, guys. Thank you so much.
In the next session. Thank you for all. Thank you. Bye-bye. See you.
Bye-bye.
Thank you, Professor.
Thank you all. Thank you, Professor.
Whoa.
Thank you, guys.
E aí?
Pô, foi show. Muito bacana. Obrigado aí.
Muito bom, pessoal.